We have a question in the room. Ashley?
Sorry. Hi, to the lady who had that question. Dr. Zavadanov himself said that in his previous study, he did not have the proper equipment and he did not follow the full protocol procedures that Dr. Zamboni had for his study, and that could explain the difference in the results. And he said for his next trials, he would have the proper equipment and follow the proper protocol. And, you know, I saw online that the MS Society of Canada has advised that, quote, for safety reasons, the MS Society does not recommend that people with MS be examined or treated for CCSVI outside of an established research protocol. As a longtime supporter of the MS Society, I'm really disappointed in the stance that you've taken towards CCSVI. Given the concerns about CCSVI expressed by the MS Society and its medical advisors, various neurologists, to MS patients, the government, media, medical community, imaging labs, etc., I want to know, will the MS Society and its medical advisors now exercise the same concerns with respect to the latest news of another study's results that made the news on March 29th? For safety reasons, have the MS Society of Canada and their neurologist medical advisors begun advising patients to stop their drug treatments until scientists and researchers can replicate the study that revealed there might be two types of MS and certain drugs that are effective for one type have actually proven harmful to patients with the other type of MS, making their condition in fact worse? Have the MS Society and the neurologist medical advisors begun, and if not, when will they begin actively advocating for the prescribing of these drugs to cease immediately until larger studies, which they want for CCSVI, have confirmed or refuted these latest results, so as not to put patients at risk of being placed on a drug harmful to their type of MS, as we now know has been done to countless patients for the past many years? Are newly diagnosed patients being advised not to begin any of these drug treatments? You're stopping testing and treatment of CCSVI because you say further work needs to be done. Clearly, further work needs to be done regarding drug treatments currently in use. Are you stopping them as well?
All right, I'm going to just break that down. You have quite a few questions that are in there, and for the purposes of those who are watching us online, just in case they weren't able to pick that up, and later on YouTube, I'm going to, if it's all right with you, break that down into two questions. And first one, dealing with the statement from the MS Society, Eva, if I can refer that to you, concerning the CCSVI testing that is being done outside of established clinics and protocols. Eva?
I thank you for the question. Let me start by answering, by explaining that the Society's role in this context is to provide guidance, information based on timely, accurate, hopefully relevant information, but to ensure that our role is as a provider of the information and that we have as a value to honor the right of people with MS to make their own decisions. So I want to make sure that that's clearly understood. In the context of CCSVI, we are, as Dr. Zamboni himself noted in his conclusions, at a very early stage, very preliminary stage in the process of discovery. And the reason we recommend that experimental treatments be sought in the context of clinical trials is really twofold. One is that a clinical trials provides appropriate safeguards for the participants, for the patients, through things like ethical approvals, consent. And secondly, clinical trials provide the appropriate protocols for the information that flows from the patient's response to the therapy in a way that can be rolled up and that becomes data that provides the answers that we need very urgently. So the reality of our position is that it balances the role that we play in serving the interests of people with MS who want discoveries today, therapies today. And we understand that. Living with MS is not easy. MS changes, progresses. It can be very debilitating. But we also want to combine that with the role that we play in racing to those answers that are important in adding to the arsenal of therapies that help us in managing the disease, in slowing its progression, and obviously, eventually, in bringing us to a cure.
Dr. Murray, I'm throwing this one out there for you. This, again, is from our question. This is referring to, I believe it was a study or a news report that was released on March 29th concerning medications.
Yes.
I don't know if you're familiar
But
with
again, that's an initial study which will require validation, but it is suggesting that there may be a marker that could identify people who would be responsive to the therapies as opposed to those who may not be responsive. The idea that we should recommend that people not take the therapies because of this initial report isn't in keeping with the results. In other words, we have good evidence that patients treated with these therapies, particularly early and when they're relapsing and remitting, get substantial short-term and long-term benefit. So we would not discontinue those therapies. What would be interesting from that study is if they can develop a marker that can be validated, that it can separate patients. Then you could decide that some patients go on those therapies and others not. At the present time, even as a group patient, there is substantial evidence of benefit in those patients. And the results with those therapies is better now than it was initially in the trials, because in the trials, patients who had the disease quite a long time were included in the trials. Now, almost everybody who goes on the therapies goes on them early as relapsing and remitting. And so the benefits now are even greater than they were shown in the trials.